12:15 Eastern Time. Let's go ahead and get started and finish up with GYN section number 3. All right, so where we left off, we were talking about minimally invasive or more conservative options for the management of leiomyomatous uterus. Another thing that we can do, of course, is uterine artery embolization. And it's been around for quite a while now. Compared to a myomectomy or a hysterectomy, you're going to get less pain, less need for blood transfusion, less OR time, and a quicker return to work. There have been documented effects. You can get a reduction of symptoms, of the bulk symptoms. You can get a reduction in menstrual flow. They have documented for up to 5 years a significant reduction in the size of the uterus, and that includes not only reduction of the actual leiomyoma itself, but of total uterine volume. However, this is not indicated in women who desire future fertility, and it should not be done in postmenopausal women. There is an increased risk of reintervention after uterine artery embolization, higher than with a hysterectomy or a myomectomy. And it's at least 15% of patients who undergo UAE will have some sort of a reintervention at 5 years. Again, there's very limited data on reproductive outcomes, and that's why we say it's not indicated in women who desire future fertility. For women who have conceived after uterine artery embolization, there appears to be increased pregnancy loss, cesarean section rate, and postpartum hemorrhage. The ideal candidate for somebody with that you would offer uterine artery embolization to would be the person who has heavy menstrual bleeding due to fibroids. She is premenopausal and has no desire for future fertility. So what are some of the complications that can occur? And major complications can occur anywhere from 1 to 12% of the time, in the minor anywhere from 21 to 64%. Post-embolization syndrome is fairly often seen, and that has to do, we think it is due to the tissue necrosis. All right, you can get pain, you can get fever, you can get nausea. Basically, you have your impeded blood supply to the myoma, so it's kind of like infarcting, and you're getting release of the cytokines and the prostaglandins, which is again going to cause problems with pain and cause pain and fever. Just like the first 24 hours post-op, we can see fever, nausea, etc., from the release of the inflammatory cytokines and prostaglandins. You can get infection, you can get bacteremia, you can perforate the uterus and have some sort of an intraperitoneal injury. But the main thing here, you can see these complications. The ones that are unique would be the post-embolization syndrome and the loss of ovarian function. And it's important to recognize this can be as high as 12 to 18%. What about endometrial ablation? That's something else we could do to try to offer our patient endometrial ablation for problems with abnormal bleeding and not have to do a hysterectomy. So it is indicated for the treatment of heavy menstrual bleeding or patient-perceived heavy menstrual bleeding in premenopausal women with normal uterine cavities who have no desire for future fertility. Patients should be willing to accept normalization of menstrual flow, not necessarily amenorrhea as an outcome. Because if you don't set them up that the goal is just to reduce the amount of flow you have each month, then you are setting up unrealistic expectations if they think amenorrhea is what is going to be the outcome. You must do a preoperative or endometrial ablation, endometrial biopsy, because you certainly don't want to be ablating endometrial cancer or EIN. You should do a transvaginal ultrasound prior to the procedure to assess the uterine cavity. And endometrial ablation is not contraception, and the patient does need some form of reliable contraception post-procedure. We've already talked about how the structure and the histology needs to be evaluated, and there's different techniques of endometrial ablation. Way back when endometrial ablation first started, I was actually trained with the resectoscope. You either used like a little ball where you went in and just kind of like cauterize the entire endometrial cavity, or we actually had like a little wire that you would actually try to resect part of the endometrium. So that's more for historical basis. What do we do now? The non-resectoscopic arthroscopic techniques of endometrial ablation. It's going to ablate about 4 to 6 millimeters of the endometrium. There's multiple different types. Now, hot liquid balloon and microwave aren't available in the United States. Minerva is a combination of thermal and bipolar frequency. The clinical point here is whatever type of endometrial ablation you do, you should understand what type of energy is being used, what's the limitation, what are the requirements, what are the parameters to use that technique, and be comfortable with that and be able to explain that to the examiner. Things that can be associated with endometrial ablation failure are a large cavity size, so greater than 10 weeks, the presence of adenomyosis. Now, adenomyosis in and of itself is not a contraindication to ablation. You're just not going to see as good of results. And let's think about this. You have endometrial glands growing deep into the myometrium. You are not treating those when you are ablating the endometrium. And in some cases, it actually can make their pain worse because basically you've now scarred the endometrial cavity. And for those endometrial glands that are deep in the myometrium and still responding to hormone stimulation, now how is that blood going to flow out of the through the myometrium and come out through the endometrial cavity and through the cervix? And so you can actually get almost like a worsening of their symptoms in pain. So not a contraindication, just decreased success. Grand multiparity. What about intracavitary lesions? If there's like a submucous myoma, if there's a polyp. So then that is the big question. Can you do a hysteroscopic myomectomy and an ablation at the same time? And the answer is maybe. For the radiofrequency ablation, like the NovaSure, possibly it's fine to do that, but the non-radiofrequency ablation techniques are not approved for concomitant submucosal myomectomy and ablation. Younger age is associated with failure. We know now that endometrial ablation maybe only has a lifespan of 5 to 7 years. So the younger the patient is when you do an ablation, basically, I kind of look at it as you're just kicking the can down the road, and you may be addressing the heavy menstrual bleeding and failure 5, 7 years down the road. And maybe that's okay. Maybe they're comfortable with that. They just want something more conservative now, but you need to set up realistic expectations. And of course, if the uterus is very retroflexed or anteflexed, you're going to have decreased ability to treat the fundus. Contraindications of endometrial ablation. These are pretty well, of course. If they have endometrial cancer or hyperplasia, if there's a current pregnancy, if they want to preserve fertility, if they've got an active pelvic infection, they've got a current IUD in situ, and some of the relative contraindications. ACOG even says in that committee opinion on endometrial ablation, the non-ideal candidate for endometrial ablation is the obese anovulator. Why? You're not treating what the underlying problem is. You're masking it. And so these patients are still at increased risk for EIN and endometrial cancer. And so risk factors for endometrial cancer, obesity, chronic anovulation, PCOS, tamoxifen use, and Lynch syndrome. These are not good candidates for endometrial ablation. Also, postmenopausal women, you really shouldn't treat postmenopausal bleeding with an ablation. Women who absolutely are adamant that they want amenorrhea, you need to set up expectations. Women who have uterine anomalies, maybe there's a septum or large submucous myomas or uterine didelphys or something, you're not going to do ablation. What about this myometrial thinning? If you read the package insert on some of the different endometrial ablation techniques, they do make a comment that myometrial thinning following uterine surgery, such as a cesarean section or a myomectomy, could potentially increase the risk for injuries to surrounding pelvic organs because the heat could be transmitted easier through that thin myometrium, but we have no data to establish the minimum thickness of myometrium that should be present. All right, complications, fluid overload and electrolyte disturbances, that's primarily seen only with the resectoscope. The other place that would be appropriate would when you're doing operative hysteroscopy and we're looking at fluid deficits. So remember, when we're doing a hysteroscopy and say we're doing a submucous myoma and we're opening up some big sinuses as we're dissecting a fairly large myoma, we can get a large amount of distension medium being absorbed into the intravascularly as well as intraperitoneally. Most of us are using like normal saline. The good news is we're really not worried about hyponatremia, brain swelling, seizures, and electrolyte disturbances as much as we are worried about fluid overload and pulmonary edema. So just know that. With endometrial ablation, of course, you can injure the cervix vagina, you can bleed, you can perforate with surrounding damage. And you should know if you took somebody in for an endometrial ablation and you perforated with the uterine sound prior to even doing the procedure, how are you going to manage that? How long are you going to wait till you would bring her back and attempt endometrial ablation again? And then some of the post-procedural issues, infection, pregnancy, malignancy, hematometra. I've definitely seen that happen before where there's scarring of the internal os and what bleeding does occur can't egress and the patient develops pain. And then there's this painful syndrome. We call it post-ablation tubal syndrome. It's associated with the prior or concomitant tubal ligation. It usually develops 2 to 3 years post-ablation. The patient develops like cyclic pain. It can even be chronic. The treatment really is to just do a hysterectomy. Maybe you could go in and resect it, but most of us would do a hysterectomy. And it's basically corneal hematometra. And the risk of that can be as high as 10%. So now let's jump into some GYN oncology updates. Let's talk about breast cancer. So the lifetime risk for the average woman is 1 in 8 or 12%. So if we live to be 80 some years of age, we've got about a 12% chance of developing breast cancer. There are certain things that increase breast cancer risk. Now, the biggest risk, the main risk for breast cancer are female sex in advancing age, and there's nothing we can do about that. Other things that can increase the risk of breast cancer are early menarche, late menopause, nulliparity, long interval between menarche and the first pregnancy, increased BMI. Alcohol use is associated with increased cancer risk, and a lot of patients aren't aware of that. Smoking can also increase breast cancer risk. Women who have dense breasts not only have an increased risk of breast cancer, but it's harder to detect the breast cancer. If a patient is on hormone therapy, if the progestin is medroxyprogesterone acetate, there appears to be an increased risk of breast cancer with that. If a patient has had high dose chest radiation, like they've had non-Hodgkin's lymphoma, and between 10 and 30 years of age, they had chest radiation, that increases their risk of breast cancer significantly. There are some also if they've had a prior breast, well, actually, these are on the next slide. So I'm going to stop here and just focus on this slide. So what else? What if we oftentimes have patients come in who say, oh, my mom had breast cancer, so I'm so worried I'm going to have breast cancer too. That if it was the mother had it postmenopausally, there's a very low added risk. But if it was a premenopausal breast cancer, that does increase her risk of breast cancer significantly. Obviously, if you carry a genetic mutation, if you carry BRCA1 or BRCA2, these are autosomal dominant inheritance. You have, regardless if it's BRCA1 or 2, you have a 45 to 85% lifetime risk of breast cancer. The difference with BRCA1 is it tends to be triple negative breast cancer, whereas BRCA2 tends to be more likely to be hormone receptor positive. And on the next slide, we'll talk about why that's important with regards to tamoxifen use. BRCA2 has versus 1 when it comes to ovarian cancer risk. BRCA2 is not as high of a risk, and it tends to occur about 10 years later in age than the BRCA1. And BRCA2 is also associated with other cancers such as male breast cancer, prostate, pancreas, gastric, and melanoma. Now, the hereditary cancers in general occur about 10 years earlier than sporadic cancer. And tamoxifen prophylaxis can be given to someone with BRCA2 because we can see up to a 62% reduction of breast cancer. There has not been a reduction in breast cancer with BRCA1 carriers with tamoxifen use. Again, it's because they just don't have the hormone receptors on it to be affected by tamoxifen. Other times where you could consider tamoxifen prophylaxis in high-risk women, if somebody has a family history of premenopausal breast cancer, like if it's a first-degree relative, you could consider giving that to any woman who is 35 years of age or older. If you have a patient who's 35 or older and has at least a 10-year life expectancy and has any one of the following, we talked about thoracic radiation less than 30 years of age, that significantly increases the risk of breast cancer, and these patients actually should be getting mammograms and breast MRIs. If they've had lobular carcinoma in situ, if you calculate a Gale model on them and their 5-year risk of breast cancer is 1.7% or higher, or if they've had a breast biopsy that revealed atypical hyperplasia of the breast. Now, tamoxifen prophylaxis can be used in both pre- and postmenopausal women, whereas raloxifene is only approved for postmenopausal women. Sometimes if somebody's postmenopausal and you want to put them on some sort of breast cancer reduction or prevention, you can consider an aromatase inhibitor, but you must check the bone density first. Aromatase inhibitors absolutely increase the risk of osteoporosis. So if the patient has low bone mass and there's no contraindication to a SERM would be preferred. Now let's talk about workup of a breast mass, because we're the ones the patients come to first when they think they feel something abnormal in their breasts, or we palpate a mass during our the breast exam at an annual exam. So if we're going to work up a breast mass, we've got options of mammogram. We can do the ultrasound. The ultrasound basically can tell us if it's cystic or if it's solid. We have the option for aspirating. So if there's a cyst that's present and it's symptomatic, so it's causing the patient discomfort, we can aspirate it. And again, usually the radiologist would do it. If it's complex cyst and the patient's greater than 30, we usually recommend aspiration. And again, sometimes the patient anxiety in it of itself is a reason for aspiration. An excisional biopsy should be done anytime there is a suspicious, solid, palpable mass. And I mean, sometimes women come in and you do a breast exam and they're like, I think I feel something. And it really just feels kind of like dense fibrocystic tissue. I'm talking about somebody comes in and you feel a mass. It is definitely different and separate from the surrounding breast tissue. That is something we need to be vigilant about following up, regardless of what mammogram and ultrasound show. Obviously, we can do a biopsy if there's on mammogram, there's a suspicious finding. If a breast aspiration was done and the fluid came back bloody, the mass failed to resolve, or it went away and then recurred, that would require an excisional biopsy. And anytime somebody has bloody nipple discharge or ulceration. Now, there is a very good practice bulletin that discusses the management of breast disease, or I think it's like management of breast disease or management of breast mass. I think it's breast disease. And it's a practice bulletin. Again, that would be a high yield review. What I love is they give two different pages of algorithms. One is for the workup of breast mass in the patient less than 30, and one is for the patient greater than 30. So this is kind of a summary of that algorithm, but sometimes it's nice to see it actually in algorithm form. So somebody comes in, they're less than 30, you absolutely feel a mass. This is separate from the surrounding breast tissue. The first thing you're to do is get an ultrasound. The ultrasound is going to tell us, is this solid or is it cystic? If it's solid, you've got a couple of different options. The most likely diagnosis is going to be a fibroadenoma, right? So sometimes we'll get from the radiologist, they will say, this is consistent with a fibroadenoma. I'll recommend ultrasound, diagnostic mammogram, clinical breast exam every 6 to 12 months for 1 to 2 years to ensure stability. Or they may say, this seems consistent with a fibroadenoma, but we recommend a tissue biopsy. So that will be more the radiologist telling us what to do. A simple cyst in somebody less than 30, you can just follow it up. You don't need to do anything. You can aspirate if symptomatic. A complex cyst, you can do either observe, aspirate, or biopsy. Again, it's going to depend on the degree of complexity and the radiologist's recommendations. Now, what if you feel a mass? You feel something. They do an ultrasound. There is no abnormality whatsoever. You've got a couple of different options, and a lot of this is going to depend on your level of suspicion. You can just have her come in every 3 months for a clinical breast exam, or you could continue regular imaging or even get a diagnostic mammogram if your suspicion is high. Now, if somebody comes in and you examine her and you really think it's just kind of dense fibrous cystic changes, it's best to just reevaluate it after 1 to 2 cycles. And then if it persists, get an ultrasound. For the patient who's 30 or greater with a palpable mass, that equals diagnostic mammogram. And if the mammogram comes back BI-RADS 1 to 3, you're going to get an ultrasound. If it's a simple cyst, same thing. You can just routine follow-up, aspirate it if they have symptoms or anxiety. If it's solid, but BI-RADS 1 to 3 on diagnostic mammogram, then this is where the radiologist will usually recommend ultrasound and diagnostic mammogram every 6 to 12 months for 1 to 2 years. But if your clinical suspicion is high, I can't emphasize this enough, doesn't matter what radiology says, you want a tissue biopsy. And so we're not going to be doing the breast biopsies. If you're really clinically suspicious, you send that patient to a breast surgeon and get a second opinion. Again, if it's solid, but BI-RADS 4 or 5, you're going to get tissue biopsy. If no ultrasound abnormality, clinical suspicion high, biopsy. Why do I keep emphasizing this? Mammograms and imaging can miss 10% of breast cancers. So you can never go wrong when you feel something that feels clinically suspicious to get a second opinion by a breast surgeon. All right, what are some other breast cancer pearls? The most common cause of a bloody nipple discharge is a benign intraductal papilloma. You would still get a diagnostic mammogram on that and refer to a breast surgeon for excision of that duct. The most common cause of a solid breast mass is a fibroadenoma. Fibroadenomas can stay the same, they can grow, they can regress. 85% of cases of Paget's disease will have an underlying intraductal carcinoma, and it can be either invasive or in situ. And I think I've hammered this home enough that and this should say false negative rate, not false positive rate. I'm sorry, that should say false negative rate for mammogram is 10%. All right, what about cervical cancer staging? We are not GYN oncologists, right? We are generalists. We do not have to sit there and say, this is what stage 1, stage 2, stage 3, stage 4 of cervical cancer is. But if you have a patient on your case list who you diagnosed with invasive cervical cancer off of your colposcopy, biopsies, LEAP, cone biopsy, you referred them to GYN oncology, you should know what stage did the patient end up being, what did GYN onc do, and what is going to be her follow-up. They did change the staging in 2019, and the changes are listed here, and it's primarily because they wanted to try to, by changing the staging, it changed what the treatment options are. So you can see 1A is just microscopic invasion, and now it's 1A is less than 5 millimeters in depth. 1A1 is less than 3 millimeters, and 1A2 is 3 to 5 millimeters. And then it kind of goes through all of this again, really microscopic, looking at invasion, because that's going to affect the treatment options. Stage 2 is the upper 2/3 of the vagina in the perimetrium, but not to the sidewall. Stage 3 is the lower third of the vagina. It goes to the side wall. You can have hydronephrosis and nodes involved. And then stage 4 is distant mets. So how does this affect treatment? If somebody is a 1A1, you can actually do a cone biopsy or a simple hysterectomy, plus or minus BSO. Again, we're not going to be doing it, but I'm just letting you know this is why they changed this. If there's a 1A2, they can do a modified radical hysterectomy at nodes. And again, plus or minus BSO. All of this is plus or minus BSO, and that would depend on the GYN onc. 2B, 1B to 2A, you're going to do, see each stage, we're stepping up what gets done. You could do a radical hysterectomy plus nodes with radiation and cisplatin, or the rest of these you're going to treat with radiation and chemo. With regards to cervical cancer, we know that HPV is present in almost 100% of all cervical cancers. And when it's not there, maybe it's just a type that we don't know how to test for. There are high-risk HPV types we seem to keep finding more and more all the time. 16 and 18 are the most commonly present in cervical cancer. HPV 16 is associated with 50% of squamous cell cervical cancers, and 8 is in 50% of adenocarcinomas of the cervix, but 18 can cause squamous and 16 can cause adeno, but that just kind of goes over what the predominant HPV subtype is. What about cervical cancer in pregnancy? Again, we are not going to be managing this, but we certainly could have one of our OB patients who we diagnose with cervical cancer based off colposcopy and biopsy. If a patient is pregnant, we are now going to involve the help of MFM and GYN-onc. If the patient is in the first trimester, you don't change treatment at all. Unfortunately, it will lead to the loss of the pregnancy, but you need to address and treat the cervical cancer. In the second trimester, oftentimes the recommendation is to terminate and treat. And in the late second and in the third trimester, this is when they're going to consider the risks and the benefits of prematurity versus delayed treatment. If in the late second trimester, if the patient is like 22 to 25 weeks gestation, and they have stage 1A1 to 1B1, which is less than 1A1 to 1B1, you can delay treatment until after delivery. However, if it's 1B1, or excuse me, stage 1A1, you can delay treatment until after delivery. However, if it's 1B1 or higher, neoadjuvant chemotherapy is recommended. Again, what you mainly need to know is if somebody is pregnant with cervical cancer, the gestational age will depend on the treatment options. All right, let's talk about VIN. I commonly see in the case list, people still calling things VIN3, and that's mostly because that's what the pathologist is calling it. Way back in 2016, ACOG says, stop calling it VIN1, 2, and 3. VIN1 is just HPV changes of the vulva. VIN2 is that wastebasket diagnosis that we don't really know what to do with. And VIN3 is really the only thing that should be considered a VIN. And there's two different categories. There's VIN differentiated, which is not HPV related, and typically the type of abnormalities that we see with lichen sclerosis and other vulvar dystrophies. And then there's usual type VIN. That's the vulvar HSIL, or what we typically call VIN3, and that is what is associated with carcinogenic HPV. Treatment is recommended for all women with usual type VIN, i.e. the old VIN3. All right, so you're going to do a wide local excision of that lesion if you're worried that there could be invasive cancer present. If occult invasion is not a concern and you feel very comfortable that this is truly just an epithelial abnormality, you can excise it, you can ablate it with a laser, or you can even do medical therapy with Imiquad. After resolution, you're going to follow up at 6 and 12 months and then annually. What about ovarian cancer? So one of the questions I often ask candidates is, all right, so you have a patient who comes in with an adnexal mass, you do an ultrasound. Tell me what findings on ultrasound are going to be suspicious for malignancy. And then for those masses that are suspicious for malignancy, tell me how you're going to evaluate that. There's a practice bulletin that discusses the management of adnexal masses. I highly recommend looking at that. It looks at the differential diagnosis and the management of masses in the postmenopausal women, in reproductive age women, in pregnancy, and in our premenarchal girls. It tells us how we can manage them, when we can be conservative, when we should do tumor markers, when we should get formal risk assessment, when we should refer to GYN-onc. That would just be a good review. So other symptoms that aren't listed here, of course, would be high color flow Doppler increase would be suspicious for malignancy, and of course the presence of ascites on ultrasound. Simple masses, so less than 10 centimeters or 10 centimeters less, even in a postmenopausal woman, if it's asymptomatic and she has a normal CA 125, can be observed. All right, what's your differential diagnosis of a solid adnexal tumor? Well, maybe it's just a pedunculated myoma, but then there are a whole host of true solid tumors of the ovary: thecoma, fibroma, Brenner, granulosa cell, and dysgerminoma. The differential diagnosis of a cystic tumor, maybe it's just a functional cyst. It could be a simple cyst, it could be a corpus luteum cyst. We just need to, and those we can observe, and most of them will be gone within 6 to 12 weeks, right? Maybe it is not going to go away, but it's truly a serous or a mucinous cystadenoma, but it's benign. You can have a serous and mucinous cyst adenocarcinoma also, right? You can have a mature cystic teratoma, you can have an endometrioma. So you need to, if you have an ultrasound, so if you have an adnexal mass on your case list, be prepared to discuss what the ultrasound showed. And a lot of times the candidates will just say ovarian cyst. But I'm like, but is it simple? Is it complex? What was the size of it? They want to know what the size is. So be prepared to discuss size also with your examiner. So let's talk about ovarian cancer tumor markers. Now, the CA-125 is going to be elevated with serous epithelial tumors, right? Take a look at here, the cause of false negative. I want this bullet point to go in front of the non-epithelial tumors because mucinous epithelial tumor is an epithelial tumor. So one of the reasons for a false negative CA-125 is it's mucinous, and that tends to more increase the CEA than it does CA-125. We know the CA-125 is not a great tumor marker. There's a lot of causes of false positives. So anything that inflames the peritoneal cavity can cause a elevated of a CA-125. And they're all listed there. Then of the non-epithelial ovarian tumors, you've got your endodermal sinus tumor and embryonal. It's AFP and HCG is going to be increased. Choriocarcinoma and germ cell tumors, HCG plus or minus LDH and AFP. Granulosa cell tumor, we can see elevated estrogens and inhibin, and then dysgerminomas. But the most important thing to remember, if you have a normal CA-125, it doesn't mean they don't have ovarian cancer. 50% of early stage epithelial ovarian cancers have normal CA-125s. So you really have to have a high index of suspicion, and your ultrasound findings are very, very important. Any huge ovarian tumor is most likely to be a benign mucinous cystadenoma. And we've seen cases of that where they're like, this woman had a 40-pound ovarian tumor. Most of those are the mucinous cystadenomas. Where else can we see increased risk of ovarian cancer besides our BRCA patients? Well, Lynch syndrome is another genetic mutation that we as gynecologists need to be aware of. It primarily increases the risk of colon cancer and endometrial cancer. So premenopausal endometrial cancer, especially somebody without risk factors, we need to be thinking Lynch syndrome. It also is autosomal dominant. So screening for Lynch can be based off of family history or tumor-based genetic screening. And what I mean by that is now universally, anyone with colon cancer or endometrial cancer will be screened. The pathology will be tested for microsatellite instability. And this has greatly improved our identification of Lynch syndrome among cancer patients, which then allows us to offer screening to their family members. There's other organs that can also be involved with Lynch syndrome. We have found that there is an increased risk of ovarian cancer and possibly even breast. All of these other ones are important, but the ones specifically important to us are the ovarian and breast. So for the increased risk of endometrial cancer, and remember, there's also increased risk of ovarian and possibly breast, a total hysterectomy and BSO is recommended once childbearing is complete. With regards to endometrial sampling, because we need to be looking for endometrial cancer or precancer changes, right? We're going to start endometrial sampling annually at 30 to 35 years of age or 10 years prior to the earliest Lynch-associated cancer. With regards to ovarian cancer, it's the same thing we can kind of offer for the BRCA patients, which we know doesn't increase the diagnosis. The best thing to do is just remove the ovaries. But again, you could start plus or minus annual pelvics and ultrasound plus or minus CA-125s. But again, we know there's really no benefit to detecting early ovarian cancer or increasing survival. The best thing is risk-reducing surgery. Now, what do we do with the adnexal mass in a postmenopausal patient? You're going to do a history and physical. You're going to do an ultrasound. Say you feel some sort of a mass in the pelvis, or she comes in complaining of left lower quadrant pain. The ultrasound, is it simple or complex? Is it, if you're going to follow it, is it enlarging? Was it documented 6 months ago and now it's even larger? Does it have any suspicious features? And is the size 10 centimeters or larger? Any simple cyst, you are going to, as a minimum, do tumor markers. Or if it's a complex cyst, you could consider a formal biomarker panel. You could do a CT or MRI to further evaluate for other things. But again, most of the time, we're not going to do that we aren't going to do it for a simple cyst. But that, again, if somebody was suspicious enough for an adnexal mass that I was thinking I should do a CT or MRI, maybe if I wasn't sure if it was ovarian and there was just this mass that I was like, I'm not even sure what the etiology is, I consider doing it then. But let's say you've got a simple mass or even a complex mass that has low likelihood of ovarian cancer. So how are you going to, tell me how you're going to do this surgery? Are you going to do a laparoscopy first, do washings, take a look at it, do containment, maybe switch to a laparotomy if you think it's more complex than that? So be prepared to discuss how you would approach an adnexal mass in a postmenopausal patient who needs surgery. If it's suspicious for malignancy, we just need to refer to GYN-onc. The chance that a simple cystic adnexal mass in a postmenopausal woman, the risk of ovarian cancer is way, way, way less than 1%. 80% of ovarian neoplasms in menopausal women will be benign epithelial neoplasm. With regards to our premenopausal women who have adnexal masses, you should be very comfortable discussing how you would manage. So somebody has a cyst, they come in, they're menstruating, how do you manage a functional cyst? When are you going to repeat it? Would you put her on birth control pills? Why or why not? When are you going to repeat imaging? And of course, the role of observation in allowing a functional cyst to resolve. Now, in consideration for the GYN-onc referral, what is considered an elevated CA-125 in a premenopausal woman? Really, we don't have a number. They just say if it's significantly elevated or very elevated, you should consider referral to GYN-onc. We used to say 200 or greater. Now, sometimes they're saying 70 to 80 might be a high enough number to at least get a second opinion from GYN-onc. CA-125 in postmenopausal, anything greater than 35. And the formal risk assessment, there's the ROMA and the OVA1 and all those different. Basically, when would you do that? You have somebody who has an adnexal mass that you have determined they need surgery. And all that does is, by assessing the risk of malignancy, helps you to decide, should I do it as a general GYN or should I refer this patient to GYN oncology? And don't forget, some ovarian cancers are actually metastatic from other primaries. And there are multiple primary cancers that can metastasize to the ovary. The most common one is the GI tract. And this is present about 5 to 15% of ovarian cancers. And I can very well remember a patient of mine who came in. She had been trying to lose weight, but then she kind of kept losing weight and kept losing weight. And she came in and she had a large right adnexal mass. And I did an ultrasound and it definitely looked like ovarian cancer. Now, she had just had a colonoscopy 3 years prior. So I wasn't even thinking that this could be metastatic from the colon, because her colonoscopy was normal. But anyway, she actually had a right-sided colon cancer, and it truly ended up being metastatic to the right ovary. This was discovered by the GYN oncologist that I referred her to. All right, let's talk about EIN. So sometimes, again, the pathologists are still using the old terminology, simple or complex without atypia or simple complex with atypia. Way back in 2015, ACOG recommended we switch this to EIN. So simple or complex without atypia is just benign hyperplasia. We treat it medically. It's not really considered premalignant. Simple or complex with atypia is EIN, or endometrial intraepithelial neoplasia. Surgical treatment is preferred. Progestin therapy is an option for candidates who desire to retain fertility or patients who are poor surgical candidates. And then, of course, next would be the endometrial cancer. And EIN is truly a premalignant precursor to type 1 endometrial cancer. If you look at the benign hyperplasia and EIM, this is the malignancy risk if we don't treat it. So 1 to 5% of benign, 10 to 25% of EIN can become endometrial cancer if it isn't already. But then when you look at, let's say you diagnose benign hyperplasia or EIN, you took them right to hysterectomy, the risk of endometrial cancer on final pathology after hysterectomy is 1 to 3% with benign hyperplasia and 25 to 40% with EIN. So the goals of newly diagnosed EIN is to rule out concomitant endometrial cancer. If they don't have concomitant cancer, we want to prevent progression to endometrial cancer. In general, it is recommended that all patients with EIN are referred to GYN oncology for surgical management. There are many candidates on their case list that they are doing the surgery for EIN, but it is truly because their GYN oncologist is telling them we are way too busy. We cannot be doing this for EIN. We are available for backup. Just go ahead and do the surgery that they recommend. So they're consulting GYN on first and then taking them to the OR. And if that's what you do, be prepared to discuss it. All right, so surgery, if a general OBGYN is going to do surgery for EIN, we need to do a total hysterectomy with or without a BSO. Again, that's going to be all part of the counseling. You're going to do peritoneal washings also. A supracervical hysterectomy or morcellation is absolutely contraindicated. You need to counsel the patient that if indeed, after I do this surgery and it ends up showing endometrial cancer, you may very well need to go see the GYN oncologist for further surgery, which may include a oophorectomy and a lymph node dissection. The other thing you can do is if GYN sometimes they say, we'll be available for backup. So open the specimen in the OR, look to see if there's any tumor invasion, consider doing a frozen section. And if that's going on, they may jump in and assist you then. So some of the medical management pearls. So if somebody has benign hyperplasia, there's a whole host of different progestin treatments you can treat them with. And I've just listed some of them. Just be prepared to tell the examiner what progestin regimen you would treat someone with benign hyperplasia on. You should sample them every 3 to 6 months for up to a year. Once you've had regression on the hyperplasia, if you think this patient is a high risk for recurrence, then just keep them on like preventative monthly progesterone therapy. If you think it was not likely to recur, you don't have to put them on preventative therapy, but you should be very vigilant about doing an endometrial sampling for any AUB. Again, EIN, treated with surgery, that's kind of a slam dunk. But if you're going to treat it medically, these are just some options. There's a whole host of other options too. You can give oral MPA 10 to 20 milligrams daily or cyclically, days for 12 to 14 days a month. You can give them micronized vaginal progesterone, 100 to 200 milligrams daily, or even cyclically for up to 14 days a month. You can give IM DUPA 150 milligrams every 3 months. There's a whole host of things you can do to treat medically. Now with EIN, you need to sample every 3 to 6 months for 2 years. The most appropriate frequency of sampling has not yet been determined. If the endometrium normalizes, you absolutely need to keep these patients on continuous maintenance therapy. If the endometrial sampling you do continues to show persistent EIN or the endometrium doesn't normalize, then you need to do a formal hysteroscopy DNC to confirm the pathology, do a pathology review, and refer to GYN oncology. Let's talk about endometrial cancer. This is the most common cancer that we're going to see. Again, you don't need to know the staging, but most likely our patients, 70% are going to be stage 1, where it's confined to the uterine corpus. Maybe like 12% will be stage 2, so it enters the cervical stroma. And then stage 3 is where it's going beyond the uterus, and stage 4 is distant mets. So type 1 endometrial cancer, this is what's responsible for 80% of the cases. It's the endometrioid adenocarcinoma. It is a global process. It is estrogen dependent, has a better prognosis. Risk factors for type 1 include endogenous estrogen from obesity, exogenous estrogen from unopposed estrogen, also tamoxifen, nulliparity, diabetes, but of course that's probably more related to their obesity, Lynch syndrome, PCOS, early menarche, late menopause, etc. Type 2 endometrial cancer is in 20% of the cancers. This tends to be more focal. It's a high grade. It is a poorer prognosis. These patients don't, this is not estrogen dependent. You can see these in thin women. So it's not women that you would typically expect to see endometrial cancer in. So the papillary serous, clear cells, squamous, mucinous, etc. Now, in endometrial cancer surgical staging, and management, we stage it surgically, right? So when the GYN oncology does the surgery, they are going to do nodal dissection, and peritoneal cytology should be done in all cases of endometrial cancer. Again, we already know 40% of patients undergoing surgery for EIN will have endometrial cancer on final pathology. The retroperitoneal lymphadenectomy, I've been talking too much this morning, includes getting the pelvic nodes. And then you're also going to, the GYN-onc will also get para-aortic nodes, which in 60% of the patients, if they've had positive pelvic nodes, the para-aortic nodes will also be positive. Now, in patients who have really low risk disease, like their G1 or G2 endometrial cancer with less than 50% myometrial invasion, and the tumor itself is less than 2 centimeters, they may not need a lymphadenectomy, but that is not up to us. That is going to be GYN-onc. And for patients who have G2 or G3, they have myometrial invasion in the outer third or lymphovascular invasion, they may benefit from post-op radiation with vaginal brachytherapy. Again, that will be the GYN oncologist. I'm just letting you guys know. You should just know when you refer somebody to GYN-onc for endometrial cancer, know what their stage was and what was the recommended therapy. Now, indications for progesterone treatment of endometrial cancer, and we are seeing this more and more, right? We're seeing young women, morbid obesity with endometrial cancer in their 30s who haven't had children yet and desire future fertility. So if somebody is premenopausal, stage 1, well-differentiated, grade 1 endometrioid adenocarcinoma with no myometrial invasion. And so before you can even offer progestin therapy for endometrial cancer, you have to do a pre-treatment DNC, not an endometrial biopsy, and you have to do a CT or an MRI to assess for myometrial invasion. Then the response to high dose progestin therapy can be as much as 68%, but 50% of people will have a recurrence. If indeed GYN-onc does decide that this patient is a candidate for progestin therapy, once childbearing is completed, they recommend a hysterectomy or a hysterectomy at the time of medical therapy. The only other person you would do this on would be somebody who is just a poor surgical candidate due to multiple comorbidities. These are some examples of the progestins you can give them, and they would need to be reevaluated with endometrial biopsy every 3 months. If somebody's had endometrial cancer and had their appropriate surgery, then basically the only follow-up that's needed is history and physical, rectal, and vaginal exam. And you do it every 3 to 6 months for 2 years, every 6 months for 3 years, and once you get out to 5 years, just annually. The pelvic exam is truly to just identify any local recurrence. We don't do pap smears anymore. We stopped doing that years ago. It's just not effective follow-up, and we don't do annual chest x-rays. Now, let's talk about GTN. This is our last segment here. So when might an examiner, even if you don't have GTN on your case list, when might they ask you about it? It will be in the part of your GYN case list where you have all your missed ABs or incomplete ABs, et cetera. Because here's where pathology could come back unexpectedly, tissue consistent with a partial mole or tissue consistent with a molar pregnancy. So gestational trophoblastic disease is just a broad heading, and GTD can be either benign or malignant. And the benign forms are hydatidiform mole or placental site nodule. The malignant forms are invasive mole, choriocarcinoma, or placental site trophoblastic tumor. So the forms of GTD that invade locally or metastasize, they are known as GTN. So those are the malignant ones. And of the most common form of GTD is the hydatidiform mole. And the mole can be partial or complete. So here's how This is going to be dumb, but I think you'll remember it this way. A lot of times when I'm asking the candidates, okay, so tell me about a complete mole, tell me about its karyotype, clinical characteristics, etc. So they're like, oh, was that one diploid or triploid? I want you to remember your alphabet. A complete mole is diploid. So if you think about the alphabet, A, B, C, D, they're right next to each other. Complete mole is diploid. A partial mole is way further down the alphabet, and P and T are further down the alphabet, so partial is triploid. All right, so a complete mole is all paternal, so you have two sperm that fertilize an empty egg. This is the one that is has the most significant clinical findings. There won't be a fetus. They tend to be size larger than dates. The risk of GTN is much higher. They're more likely to have bilateral fecal lutein cysts, hyperemesis, elevated thyroid functions. They can have even atypical preeclampsia symptoms, and the HCG levels are highest. With a partial mole, it's an egg that has been fertilized by two sperms. There may or may not be a fetus. Oftentimes the size is less than dates. The GTN risk is much less, and it's rare to see fecal lutein cysts, and you'll have a lower HCG. But the bottom line is, if you diagnose this post-evacuation, we'll talk about how you manage it. And if you suspect it pre. All right. DNC in the OR and proceeding with ablation, as long as she understood that should this ahead of time. Looking back, I should have taken her for a separate trip to the OR for hysteroscopy DNC. 25% can, all of this will depend on at anesthesia induction, contraception during the monitor has been fertilized by two sperms. There may or may not be a fetus. Oftentimes the size is less than dates. The GTN risk is much less, and it's rare to see fecal lutein cysts, and you'll have a lower HCG. But the bottom line is, if you diagnose this post-evacuation, we'll talk about how you manage it. And if you suspect it pre-evacuation, we'll talk about how you need to manage it. So let's say you have, again, a suspected or a confirmed molar pregnancy. So you get an ultrasound, you've got that like snowstorm effect in the ultrasound, and the patient is size greater than dates, and let's say her HCG is 100,000. So you're going to do uterine evacuation. You need to do suction and sharp, and ultrasound guidance is recommended because these patients can bleed. You need to have your postpartum hemorrhage kit in the room with you, and all of your uterotonics and like some sort of a Bakri balloon. You need to have type and cross ready also. You're going to give her RhoGAM if she's Rh negative, IV oxytocin at anesthesia induction, contraception during the monitoring period, and you're going to do there was a new update that is ACOG endorsed. It's from the GOG, and it was from December of 2021, and it is the talks about the management of molar pregnancies, and this is where these shorter follow-up times come from. So a partial mole, you can actually stop once you get your first negative HCG, and a complete mole, you're going to do weekly until negative, and then once it's negative, they want 3 more negatives. Now, when would you do a hysterectomy for a molar pregnancy? These are for the patients who are at the highest risk for GTN. So if somebody is greater than 40, size greater than dates, HCG greater than 100,000, bilateral fecal lutein cyst greater than 6 centimeters, all of those increase the risk of GTN. And so you could actually offer a hysterectomy for that patient. If you have a suspected GTN that has developed after a molar pregnancy, meaning that the values have plateaued or increased during your follow-up, there's certain labs you need to do. You need to go ahead and, again, you were doing the HCG, but we want to know the baseline HCG because all of this will depend on prognosis. Most of us would just refer this patient directly to GYN oncology, but they're going to be looking at the initial HCG level when we refer them. They're going to get a CBC. They're going to look at liver enzymes, just overall electrolytes. The TSH, if their HCG is greater than 100,000, they're going to get a TSH, and they want to type and screen basically to check for if you hadn't done a RH typing, which you should have, but also these patients can start bleeding pretty significantly with a recurrence. You're going to get an ultrasound to see what the uterus looks like. Is it full of molar tissue? You're going to get a chest X-ray looking for lung mets and a CT of the abdomen and CT of the MR or CT or MRI of the brain looking for brain mets. GYN-onc will treat these patients with chemotherapy, and it can be single or multi-agent chemo. When we look at the staging for GTN, again, you don't need to know this. You just need to know that the GYN-onc, there's the FIGO is like an anatomic staging. The WHO is a prognostic system. They kind of use the two together, and they combine look at the risk and decide if this patient is a single agent or should be on combination chemotherapy. Things that are going to increase the risk of, or which are worse prognosis, is older age, longer duration from antecedent pregnancy, if the type of prior pregnancy, what was the pre-treatment HCG, how large is the tumor, where are the mets, the size of the mets, etc. And when we look at GTN, I typically think of GTN also always is just occurring after a molar pregnancy, but that's only 50% of the GTNs. 25% can actually occur after a pregnancy loss or a tubal ectopic. 25% can occur after a term or a preterm delivery. So we have to keep a high index of suspicion. So if you have a complete mole and you evacuate it, that patient basically has a 20% chance of developing GTN. Most of the time it will be local invasion, but they can also have metastatic disease. If a patient has one molar pregnancy, they may ask you, what's the likelihood I can have another one? So the baseline risk for anybody is 1 in 1,000. If you have a molar pregnancy, your risk for a second one is 10-fold increase, but it's still only 1 to 2%. And you can see if you've had 2 moles, you have even higher. And if your patient is hyperthyroid from the GTN, they need to be loaded with beta blockers prior to anesthesia. All right, right on the money. I got done at 1:10. I'm so proud of myself. All right, now let me go ahead and look at some of the questions. One is, how do you discuss a patient that you did an endometrial ablation on that was in a same-sex relationship and does not have penetrative sex? She had a difficult office exam, so endometrial biopsy was not feasible. I did a hysteroscopy D&C prior to ablation in the OR, but did not have the path report ahead of time. Looking back, I should have taken her for a separate trip to the OR for hysteroscopy D&C, or even explore the possibility of a frozen section in the OR prior to performing an ablation. All right, so this is real life, right? I can sit here and talk about all these ideal things that we should do. So a couple of different things here. What you could do is you could talk about this patient. Well, let me back up. You could say this patient had normal menses. She just had heavy menses. She was normal weight. Her menses were regular. They were just heavy. An ultrasound was normal. She was ovulating, and the fact on my index of suspicion for endometrial pathology was low. I would have preferred to do an endometrial sampling prior to taking her to the OR. I talked to her about doing a D&C and then getting tissue back and then taking her back for ablation. I talked to her about the pros and cons of doing a hysteroscopy D&C in the OR and proceeding with ablation, as long as she understood that should this come back EIN or endometrial cancer, I would refer her to GYN oncology. And this is where informed and shared decision-making comes into play. So I think if it was me, that's how I would discuss. Obviously, if this was a patient was obese, she was anovulatory, she was PCOS, then you should have said, no, I am doing a D&C first and then we'll go back and do an ablation at a later time. But if you can discuss that you felt that she was low risk for any abnormalities, and really a frozen section is not that accurate when we're looking at endometrial tissue anyway. So that's how I would explain that. All right, so another question is, when listing ultrasound results in the case list, how much detail should we give? Well, I'm doing this lecture right now prior to case list submission. And so as a minimum, you should give the size of the lesion, like was it 10 centimeters, 3 centimeters, and was it complex or simple? And that's really all you have to list. And you should be able then to discuss the rest. And if you don't have that on your case list, then you should know for each of your adnexal masses how you would tell the candidate or tell the examiner what was the size, and was it simple or complex, and how suspicious did you think it is? Another question on the case list, should we use the ACOG EIN terms or what our pathologist uses? All right, so that's always the million-dollar question. You know what I tell candidates to do? It doesn't really matter. What matters is that you know the proper terminology. So if you list what the pathologist put down because you truly are just putting down, this was what my pathology report said. If the examiner asks you about it and say, tell me about this patient that you did a hysterectomy on, you could say this patient had, per our pathologist, had complex hyperplasia with atypia, which I know should be currently called EIN. So you can just correct that verbally. Sometimes I'll tell people you could put what the pathologist put down and then put a parentheses EIN, just to let the examiner know that you know the proper term, but it doesn't really matter. What matters is you know what the correct term should be. I hope that kind of makes sense. All right, any other questions? All right, well then, you guys are on break. Dr. Peggy